are back, and I think we're better than ever. We have the live episode of the Compliance Guy Monday Roundtable going on right now. So joining me today, and look, some of you are probably saying, wait a minute, what's going on with your picture, Sean? Hey, listen, I've been told 100 times I have a face for radio. So I'm in a makeshift office today and the lighting is horrible, so I apologize. But the good news is you get to look at much better looking people than me. So with that said, I'll start with the best looking of them all, which is Stephanie Allard. I got Joe Rivet, Jordan, and David. And just for the three guys, in no specific order was I naming who was better looking than the other. So just, I want to put that out there.
Like Curly, Larry, and Moe. We're good.
All right. So listen, I know it's been a little while since we have been on. I know we have all missed y'all. And with that said, let's go ahead and jump straight into the program. I want to start right now by talking about a big issue that I blogged on a week ago, and it got a ton of hits. We started talking about it before we came on air live, which is what happens when an ADR, an additional documentation request, is issued, or there is an investigation by a unified program integrity contractor for documentation, and that documentation doesn't specifically, in hindsight, say everything that the physician was wanting it to say, or the provider of care was wanting it to say. And then for whatever reason, they get this bright idea that I'm going to go back in there and I'm going to modify the documentation so that it's more clear, it's more concise, it paints a better picture for what transpired, versus recognizing the fact that the documentation is what it is, and altering an original document could escalate the situation to something way beyond what you are even thinking it could. So let me pause there and let me start with Stephanie, because Stephanie, you probably perform more audits than all of us combined, right? I mean, I still look at documentation. I know David does as well, but talk about some of what you've been dealing with respect to finding these types of situations, and then we'll get back into some of the other conversations.
Yeah. So, I always talk about the work that I do. I've got two sides, right? So there's the preventative side where we're looking at education, best practices, all of that. Then the legal defense side, working with the attorneys when we've got that, oh no situation and we've got to deal with defense. So on the defense side, one thing that I've seen recently, we were talking about this before, was a client of mine is in a situation where they're leaving an employer, and that's gotten very messy from the legal standpoint. And a prior practice is trying to demand that this physician go back to documents that are over a year old for wound care services and put in essentially their checklist of items that they feel are not present. Now, when I was going through documentation, everything is there. It's actually very thorough what he has in the notes already. For me, from a defense perspective, I have no issues. But an inexperienced reviewer on the other side wanted to see it in basically, the same terms CMS would use, for example. They really don't understand how to look at that documentation. They wanted it their way. They didn't want to accept it any other way. So that's been a big issue. And then from the preventative side, a lot of times when I work with a new client, for example, and I know that there's no coders, and we have the providers responsible for their coding, and then a billing team that handles getting claims out the door, there's always a really big issue because there's a disconnect in timing. So I'll say to the billing lead, for example, does your team know if notes are complete before the provider submitted codes over? Or maybe to administration, does your system allow that provider to push a code over before they complete documentation? Sometimes we're able to put a stopgap in there where they're not able to move forward. But what I've been finding is, when we've got these providers that are chronically documenting late, that billing team's going in and they're keeping everything tight 24 to 48 hours after that particular patient was seen. And we've got documentation that's incomplete, not signed. I've had situations where, they forget to go back and complete a note, so there's no documentation. So from both perspectives, it creates a lot of challenges.
So, Joe, let me come to you real quick, right? So again, you're not giving legal advice, you're not giving legal guidance, but let's talk about the potential risks that exist. And David, I'll come to you as well from the payer's perspective. Let's talk about potential risks of, like what we were talking about prior to getting started. So a nurse practitioner, for 90 days is behind on their documentation. And they average, let's just for simple math purposes, let's just say they average 20 patients a day. So that's what, 80 patients a month. That's 160, that's 240 patients in 3 months, right? If my math is correct. I'm not a mathematician. So somebody, if I got it wrong, you're going to have to help me. All right. So hypothetically, and actually, this is a real situation, Stephanie, because we've dealt with this. So a nurse practitioner is behind 90 days on his or her documentation. During that period of time, they get an additional documentation request. The nurse practitioner is told by the physician, by the administrator, hey, there's no documentation that exists in the medical record for this patient for this date of service, and we've billed for it. You need to go back into the system and you need to create documentation right now to be able to support this. What are the risks associated or the potential risks associated with that, Joe?
Well, the potential risk are really that provider could face criminal charges, felony or misdemeanor, depending on their state law. Because if it's found that those entries were intentionally and willfully placed, so they really had a reckless disregard, they're placing misleading information that wasn't truthful and accurate. And I think you could poke a whole lot of holes in that to say, based on kind of the volume that you have there, if they're just simply going from memory, I'm not so sure how truthful and accurate those entries would be. And they certainly could risk some very serious charges, which would then implicate their licensure. So you're kind of playing with fire of potentially career suicide to some extent.
Hey, Joe, let me throw this in there, and Stephanie, I'll kind of lean on you guys. The other thing that we see, and I'll tell you, we see this a lot in the oncology specialties, is now a lot of these notes are not being started by the physician. They're being started by other staff, right? So other staff starts the note, the doc finishes them. And so I think that's becoming an issue too, especially when a note gets started, but it may not be finished until 2, 3, 4 weeks later. And I think that's becoming a problem too, is where do they blur those lines of who starts the document? And now with AI, we've got, auto generation of creating a document. And I just see this as a big liability from the False Claims Act exposure, the risk exposure, and would love to get y'all's thoughts on that.
Well, and one thing I would say about that is it's going to stand out. So, regardless of the reason I'm looking at documentation, and over the past year, I've also been starting to do some work on the payer side. And, I had a particular case where I was looking, and one practitioner, it was questionable that they were seeing all these patients or supervising appropriately. And at the time of request of documentation, there were all of these signatures. And to your point, Jordan, someone else started the note, and then it was a different practitioner they were supposedly supervising. But yet a year and a half later, on the day they received the request, all of these signatures are placed. And, it's just such an easy red flag to start questioning the content of the note.
Yeah. I mean, it just, coming from the payer side, the ZPIC, UPIC side on the audits, I mean, that's one of the first things that we look for is the documentation. Was it done contemporaneously? What is contained in the file? And, to your point, if it gets developed or, entered a year later or even a couple months later, that's going to be something where obviously we're going to challenge that. We're going to, question the credibility of that note, the authenticity of, what the documentation was. The other thing that we used to see in situations like this, and the irony is when you talk to the person, they received the treatment, but the bottom line is not documented, not done. I mean, that's just kind of the standard. The thing that you would find out though, is once you're trying to put these in, the notes start looking a lot alike, because if you have a type of patient that you're treating, a lot of times it's the same condition, it's the same stuff. So it's easier to kind of rinse and repeat. The problem is the documentation it's not aligning, and it lends itself to, as Joe said, now you're looking at different liabilities and other things that can happen, not maybe by intent, but more just by poor record keeping.
And, one of the things that I want to go back to, because again, I think not taking the time to understand all of the things that could come from what somebody thinks is an innocent situation, or whatever they want to refer to it as, a simple mistake. Folks, they're pulling metadata. That has become a very common practice right now with audits. And if you're not familiar with the term metadata, that is the keystrokes. Every single person that logs into the system for that note, it shows the date, the time, all the way down to the seconds. It shows what was created, what was deleted, what was corrected. It shows everything. So if you think that you're going to go into the medical record and you're going to add additional content to try to, quote unquote, as it's been said to me, beef up the note to support the services that were billed, you're making a colossal mistake. And you could be making a catastrophic mistake, one that leads to referral to the DOJ. Well, let's just say it's the UPIC. The UPIC's going to make the referral to the Office of Inspector General and or to Program Integrity at CMS. CMS and OIG can make a determination on whether or not to escalate it to the DOJ. So, Joe, from an attorney's perspective, I mean, you were a prosecutor, correct?
No, I was on the defense side.
Oh, I thought you were a prosecutor. Well, I know you deal with a ton of prosecutors.
Yes.
So how much would you believe prosecutors are salivating when they get from Program Integrity or from one of these safeguard contractors a referral that they pulled the metadata, and the metadata specifically shows altering of the original medical records to enhance the documentation to support a higher level of service than maybe what they should have been paid for? Yes, and how do you defend that?
Yeah, I don't know. I mean, it's certainly problematic. I've used metadata to defend something, particularly where the payer is saying, hey, you don't have a time entry. We're actually able to pull that. It's pretty helpful. But it can also hurt you based on what you described. I mean, I don't know how you would come up with a defense with that, frankly. Because I mean, you're altering the record after the fact, and for what purpose? And usually by the time you're getting these letters, it's well past the date of service, maybe a year or more. I think that's going to be a hard hill to climb, frankly.
I think
the defense that some people would like to use, Jordan, I'll give it right over to you. I think the defense that some people would like to use, which is a non-justifiable defense, is stupidity.
Yep.
Stupidity is not a justifiable defense. Go ahead, Jordan. I'm sorry. I didn't mean to cut you off. And I know you do a ton of work with metadata.
No, absolutely. And I think that's one of the things we look at closely. And I think the blind defense of any compliance plan or program to say that we'll get to it. It'll be defendable and defensible if we ever get called to the table on it. That's the stupidest defense ever. Because it's not about necessarily right or wrong as much as it is, how much is it going to cost you to prove whatever point that was completely avoidable that you have to do now had you just done it when you said you were going to do it and when you attested to it. And I think that's the bigger issue. So Stephanie, I'd love to get your thoughts because I know where you were going with that.
Yeah, so and actually I was going to talk to the AI side of it too, because one of the things that I'm seeing is that everyone's trying to implement AI, and I've got clients who are bringing it into existing EMR systems, and then I have others who are building their own and adding an AI component. And the thing that really scares me about that, especially thinking about defense, is that I'm seeing the behavior of physicians and APP practitioners change, where they're not focusing on, oh, wait, this is a legal record. What does this look like in continuity of care? What does this look like in malpractice? All of these things. I'm literally seeing situations where an assessment and plan will say, I'm putting in these words because AI will not let me document similar to the last visit. So the patient is doing well, I'm continuing care, and this note is different. I seriously had a situation where we had to pull notes like that, and then the provider, the physician, had to go back, and it was a lead physician, by the way, who was, that's questionable in itself if this is the behavior, but he had to go back and do all kinds of addendums. And to your point, David, every addendum he was adding in was rinse and repeat.
Yep, and that's I think the challenge, and you're seeing this with AI anyway. That is starting to be something where people, especially in the healthcare arena, they're much more seem to be concerned about it. They aren't as they thought it'd be great, but to your point, it's creating other issues, and I think that's a good thing. People are putting pause in there before they're letting everything go. But the challenge is you get into these things, and what we're seeing too, part of what is coming with CMS is because they're moving from the pay and chase model and they're moving more towards the prepay, this timeliness of notes is going to become much more important because they're going to be looking at claims before they pay them. So if you're billing within 24 hours, you're on a prepayment review, they're asking for records 7 days later, you're used to doing them 30 or 90 days out, you're going to have all kinds of problems. It's going to get worse because the pressure is coming to where they're putting more focus on the prepay.
I think, David, the best practice I tell clients is don't drop the claim until it's completed and signed. Now they're like, well, that will hold up our AR. Well, then you got to change your goals and priorities, I guess. I mean, because it's a very real risk because you're dropping a claim with no note or an incomplete note. And I think to Stephanie's earlier point, now you're going to have to play catch up. And it certainly increases the risks of that practice, particularly from a prepay standpoint. I mean, typically those records are due within 30 days.
Well, and the other thing that you're going to have in addition to the legal issues, and we used to, again, CMS developed this rule about probably 12 years ago, which was basically the 3 strikes and you're out. So if you have a pattern of behavior like this, where you're not compliant, they're just going to revoke you from Medicare and Medicaid. So now you're in a situation where you're losing your ability to actually generate funds just because of, bad policy and bad behavior.
And what people don't realize, Jordan, you're on mute. I don't know if you're trying to speak to us. What a lot of providers
Now Sean cut out.
Yep, now Sean cut out.
Go ahead, Jordan.
don't realize
He's back.
One's adds into the national physician.
Yep, Sean, you're in and out.
You're phasing in and out.
So we'll take over for Sean for a second. But no, what I was going to say is, Stephanie, this is attestation, right? When you drop that bill on that claim, you're attesting that everything has been done. And to blindly, again, like we said, I know we beat this horse to death. That's why they're looking on the front end. They know this is becoming more common. And so essentially that's what they're looking at. And that's why they're looking at it. is no, people aren't doing it. And it's not a defense to say, well, don't worry about the day it's signed. It's all about the date of service. That's not a defense, because when that claim, to your point, and I think Joe and David, that's what y'all said, is they're dropping the claim next day. Next day, all of ours are dropping the claim. So, it's a workflow issue, and change your workflow.
Well,
I think it's,
go ahead.
oh, sorry. Well, I think it's helpful to remind people that at the bottom of that claim form, the physician is signing. And then on the back of it, there's a whole lot of fine print that's really hard to read because it's small and really light in color. But I mean, you're attesting to this, and it's essentially a legal agreement that you're saying, yes, these charges that I'm submitting are true and accurate, and they're documented. And if none of those things are happening, then I mean, you essentially have a false claim. So,
no, that's a good point. That's a good point.
Yeah.
So, Steph, anything else?
Right.
You want to go to the next subject?
No, yeah, let's go ahead and go on to the next. I'll take over right now with Sean not here.
All right, go for it.
So going into the next one, looking at, I equate what we're going to talk about to the issues related to all of the auto downcoding that's happening. And, on the physician side, there's a lot of frustration to what it's adding into administrative work and things like that. But we're seeing a lot of documentation where the providers are trying to state that the patients are very ill. They're high risk, they're highly complex, they'll use buzzwords like that. But then throughout the documentation, outside of their buzzwords, we're seeing that these patients are stable. And, for me, it's frustrating because I hate that auto downcoding is happening. I don't think it's the proper approach. But at the same time, it's, working with clients, you've got to look at what it is you're doing. And if you're receiving auto downcoding and you don't have a way to defend that, what are you doing internally to address this?
No, I think you bring up a good point. I mean, I think that's, on our side of the house, we generally less MDM, more time-based. And so, but then if they don't bill on time, they just say, we often hear, well, we just do 99213 or 03 for everybody, which is also a horrible reason to do things. I'm like, come on, you're killing me. But to your point, I think you really, a lot of people still bill based on medical decision making, and you've got to make sure that it truly reflects, especially if they're going that route. Again, this comes back to post-payment review, this auto downcoding. They wouldn't be going down this road if, and I think of the CERT report, which they released, I think the CERT report last month, CMS did, which I have the comprehensive error rate testing report, which I looked at because it's got all the service lines. But like, they wouldn't be doing this stuff if there wasn't some validity behind it. Now, I agree. I think throwing the blanket over the whole thing and saying this is how we're going to do it is not right, but it further scrutinizes how loose or less regimented we've been with how we build these E&M codes.
Well, I think part of this is, and Stephanie, tell me if you're seeing this too, is this also comes to another issue with where they're doing the adjustments to the managed care to their fees. So what they do is they have the risk adjustment come in. So the doctors are being told to add these because that makes them adjust the risk adjustment. The plans get to make more money. The problem is on the back end, to your point, it kind of fits with what they're saying, is the patient's actually stable. So what they're seeing is okay, you said your population is this much sicker, but we went and looked at the thing. We're not seeing increased treatment for diabetes. We're not seeing increased treatment. So it ends up being something that's being done on the back end for a risk adjustment. So
right. Well, and it's funny you say that, David, because one thing when I'm working on educating in that space, especially with risk adjustment, I forget the particular case, but the OIG had a report last year where they were talking about the fact that when they went after one of the payers, they were looking at that history and they said, not only was it, shady the way you went and got this information, but in addition to that, you reported it one time. You didn't even show that someone followed the patient for that condition, other than the one time you tried to capture all of this information. And, even with ongoing UPIC audits that have nothing to do with wound care or with risk adjustment, I'm seeing it in wound care. They are heavily digging into claims data and they're saying from December 24 to September 25, why did you do this? And they're questioning a later date.
Yep.
So
I mean,
it's really interesting how that's being used.
Yep.
yeah, and it's part of the OIG work plan is to watch for that. So I mean, it's on their radar.
And I want to say thank you to you guys for. I'm so grateful that I have you guys that are podcast professionals, especially Stephanie. She knows what it's like to deal with this. Utility company apparently is digging up something outside here. So, there's one thing that I wanted to go back to because, if y'all gave the citations to this, let me know. But the question that I get from people when it comes to the requirements for timely documentation, the exact language states, quote, Medicare requires provider notes to be completed as soon as possible after service, typically within 24 to 48 hours to ensure accurate records. The key guidance is provided in the CMS IOM, which is Internet Only Manual, Publication 100-8, Medicare Program Integrity Manual, Chapter 3, Section 3.3.2.5. And then it can also be found in the IOM, Publication 100-4, Chapter 12, Section 30.6.1. And it states, again, documentation. Now listen to this. Documentation must, it doesn't say should, it doesn't say could, it doesn't say you can consider doing it. It says documentation must be finalized before submitting claims. And that specific guidance comes from Wisconsin Physician Services. That's WPS. WPS says under their best practices, they recommend 24 to 48 hours for finalization, as CMS does not define a strict, universal, quote unquote, as soon as practical time frame. So again, the only other thing that I want to share with you, because we were talking about delayed documentation, it specifically states here in the CMS Program Integrity Manual, if a note is not completed at the time of service, providers should avoid late entries and use an authentication/attestation statement instead. I mean, let me quickly go, because every one of you is a compliance professional. Would it not make sense to have a policy on the timely completion of documentation? Because Joe, as an attorney, prosecutors love to say, you should have known, right? It's not you can know. It's not you may have known. It's you should have known. Why? Because this is published guidance. What say each of you, please?
Well, I would say to that, if I'm thinking about my situation in the defense side, it's just going to be that much weaker. So yeah, I could say that, okay, we've got these points here. That's what's required per the guidelines. But then typically what I have to lean on in my situation is then the attorney who needs to come in and fight those, everything you're talking about, Sean. Is there any way from the legal perspective to argue why that could potentially be allowed? But one thing that's important to realize with that too is you are absolutely setting yourself up for a situation where you have to be defended. And, I'm constantly hearing from people where, and I'm just going to say it, they want me to take pity because of the situation they're in. They want me to reduce my rates because they got themselves in this situation. But then how many times do we also have clients where that's my findings from a review and they don't want to hear it? Or that's going to disrupt so-and-so and he's the golden child of the practice. I don't care. Like that's not what I'm here for. And if you get yourself in that situation, then you're going to have to pay for it. So, skirt the line now, pay for it later. You've got to decide what you want to do.
Yeah, that goes back to that what you said. The defense is it's not a defense to say, well, we'll defend it when we have to. It's like these rules, to Sean's point, what's in the Medicare, the program integrity manual, what WPS has, these are all precedents that again make your defense less strong and weaker when you're looking at this, because there is documentation. Then you get into the whole, well, what is standard of practice? So then we're going to look at it at your local level, and then a wider level, state level, a regional level, and what is everybody doing? And they're going to pull all that in. So now they've got MAC documentation, they've got CMS, what's in the program integrity manual, they've got your peers, and it's an uphill battle. And now what you thought was just a blatant, no big deal, I'll defend it when I need to, you spend a ton of money, and there's a good chance you're probably going to lose.
Well, and having testified in trials, for DOJ, for the U.S. Attorney's Office, when you have a situation like this where you have the ability to take the record, say, when was this created? Oh, this was done at that time. Okay, now we're going to go to the next one. Yes, it was done at this time. I only got to do about 10 of those before you show a pattern of behavior that everybody's going to say, yep, you should have known, and here's the pattern of behavior that you continue to do. Therefore, you're now in a very bad situation.
Joe, go ahead, please.
So I often wonder when we're in these situations, what got us here? And in the whole industry, if you're RVU incentivized, you got to see so many patients per hour, and you're running through them. So then at the end of the day, you're trying to chart along the day, you're in committees, you have a life, etc. Certainly not creating excuses, but if we have the continued erosion of reimbursement, we have payers that are not willing to negotiate decent fee schedules. Now we got prepayment reviews. We have down coding, as Stephanie mentioned. I think it does make a difficult situation. So I think the industry has created this environment that has led itself to this behavior. I'm not saying it's right. It's certainly very risky and dangerous for all the reasons that everyone's pointed out here. But have we kind of created this to some extent? EMRs, blessing and a curse, for a variety of reasons.
Yes.
Does it make us move quicker? Yes. I think it also makes a lot of things sloppier with tons of discrepancies. Does it get me through my day faster? I'm not so sure. But if we have this productivity of seeing patients, which I think is bizarre, I don't know that we'll ever be out of the situation, frankly.
Well, I think that's what's happened. Like, I could trace it back to my days, and I'm going to be very careful not to mention some of my prior large employers, but I worked for, back in the 90s and in the early to mid 2000s, the two largest integrated delivery health systems. And it was a race back then to see who could hire more primary care physicians, more specialists, etc. And what you found, to your point, Joe, was the incentive for them to be able to open up their schedules. Where they were in private practice, they may have been seeing 20 to 25 patients a day. Now they're being pushed to see 40 to 50 patients a day. It's all RVU based as opposed to a blended mix. And what happens is it incentivizes the providers to select higher levels of service. The documentation is sloppy. This is where cloning became a big issue. I mean, listen, we all used to gripe and complain. We're all old enough, except Jordan and Stephanie. So three of the five of us are all old enough to remember handwritten records. Back when we used to say,
"Hey, Sean, I've worked with handwritten records."
Okay, fair enough. I was trying not to age you. Come on, man.
Not 100% of the time.
Okay, but think about it. We used to say all the time, God, their handwriting is atrocious. What does this say? You can't read it. Now we look at it and we kind of say to ourselves, man, I wish we could go back to some of the handwritten notes, because these EMRs, nobody is going through and purging the medical record, right? So we're finding otitis media that was diagnosed for a patient 10 years ago as still on an active problem list. You know, we're finding medications, you know, like Augmentin, Biaxin, you know, a Z-Pack for, you know, patients who may have had a bacterial infection, you know, 2 years ago, and it's still on there. And as a result, these EMRs are producing, you know, 7, 8, 10, 20 page records for one visit. And the doctor's like, well, I mean, look at the volume of the documentation that I have here. I should get a level 10. They're just lucky it stops at a 5. And I'm like, are you kidding me? I mean, this is the insanity. And I point my finger at two groups of people. One, the administrations that have allowed this behavior to exist. And I'm talking about political administrations dating back to, you know, the first Bush, you know, the second Bush administration, into the Obama administration, into the Trump, into the Biden administration. And now what we're finally seeing is the second Trump administration is what? They're bent on ferreting out fraud, waste, and abuse. And I think they've gone from one extreme to the complete other. The second group of people I point my finger at are the administrators, to Stephanie's point, who said, this is the golden child. This is the high producing physician. I can't afford to make him or her mad because they're going to leave. And you know what? Some of these organizations that got audited and had to pay back millions of dollars or got forced into a corporate integrity agreement afterwards said, boy, I wish we would have got rid of that physician a long time ago. So let me pause there because I saw, Joe, you were getting ready to say something.
No, I completely agree. I mean, I think it's going to be a systemic problem. And the EMRs with like otitis media with 15 pages. I don't know, Stephanie, how you do it, but it's you flip through them and you can just put a red X through all the stuff that you don't need. Yeah. So it just keeps getting carried forward. Yeah. It's kind of, I miss the paper records, honestly.
And I tell providers all the time, listen, I get it. You don't want to mess with your EMR, but do me a favor, select the level of service based on what you actually did today. And if you had a patient presenting with one chronic stable problem that's well controlled and you're not doing anything for them, it's a level 2. If you don't want to change the 20 pages of documentation that's being spit out, at least be pragmatic and bill a level 2. Maybe it's a level 3. I doubt it. I haven't seen a lot of, you know, one chronic stable conditions with no change to anything that really ever supported a level 3. But I don't know, Stephanie, you tell me if I'm wrong.
Well, under the guidelines now it could, but it's going to depend on documentation though.
Right.
And you know, there's so much that could be said about an EMR system. That's another area, just like payers. I'm super frustrated with the developers that do not have proper compliance input on their teams. But that's also why, as a part of my audit process with my clients, follow-up, yes, could be education, could be workflow related, but we heavily have to dissect their EMR and see what we can do to make that better, unfortunately.
All right. So I think we have thoroughly beat this horse into the ground, but it's such a critical topic. I mean, we could keep going because there's other avenues that we could go down, but we have a couple of other topics I really want to get to. And one of them has to do with contract management as part of your compliance function. And, you know, Joe, this was something really that may have existed subconsciously in the back of my mind, but I don't really think about it unless somebody brings it up. Right. And, you know, in all of our email dialogue that we had last week, trying to talk about what the topics were, you brought up a great point, because not only is it a compliance issue, it could also be a cost issue for practices that aren't paying attention. So let me stop there and let me give you the floor.
Yeah, so I think spring is a good time. Contract management, it's probably one of the things that's really difficult, regardless of the size of your practice. You could be small or you could be multi-state, whatever. Contract management really, really important, and really these things all come about by discovery, usually internally, of like, oh my gosh, we've been paying X amount of dollars for this long and we forgot to terminate this agreement. Now we got to try to get out of it. And a lot of these contracts, particularly if they're software related, I can add Stephanie, Jordan, David, and Sean. Very easy to add people. So now my next invoice, I'm paying for all of those individuals, whether it's a clearinghouse, an EMR, whatever it may be, dictation system, etc. But now I have residents and fellows, so I add them. So now, and it keeps going. Residents and fellows kind of shift through maybe yearly or every 2 or 3 years, staff changes and goes. They never come off that list until you notify the vendor. So all of a sudden you have a 30 practice group, but you're paying for 130 licenses. Nowhere in history would you ever have that many. And this happened recently with the client where it's like, how did this happen? Exactly what I described. And then it turns out that they really actually no longer needed this agreement anymore. So now we got to try to get out of it. And it can become really, really costly. So it's just one of those things. I think it's easy to overlook in the day-to-day business of just how hustle and bustle everything is, but really having good oversight of these contracts, regardless of how small they are. Even if you're using your Outlook calendar, if you enter into a new agreement, at what point in time do you want to consider terminating? Automatically calendar that out, just like you would do like an appeal. At what point do you need to have certain things need to be delivered and received back? You don't have to have some crazy expensive system, but you need to keep track of those because it could be really costly. In this example, roughly $500,000. So real dollars.
Yeah, and David, I know you kind of chimed in a little bit on that over the weekend, and I want to let you get to that. But let me put it into another form that maybe some folks not really thinking about this would relate to. There's a program that you could go out and you subscribe to it, and it will go and look at all the paid subscriptions that you have. Well, I didn't realize I was paying for 2 Netflix accounts. I was paying for 2 Disney accounts. I was paying for this. I was paying for that. And I kid you not, it literally knocked off about $180 a month in charges. I kid you not, in charges that I did not realize because they were automatic payments going to whatever my credit card is, right? And, some of you may say, well, shame on you for not looking at it. You're right. Shame on me for not looking at it. But when I got the notice after I paid the $10 to subscribe to this program and I looked at it, I was like, oh my God, I've been paying for all of this stuff about $180 a month for almost 2 years. Do the math. And I was like, I can't tell my wife. She's going to murder me. She's probably going to watch this and find out, or, somebody's going to text her and be like, hey, did you hear what your idiot husband did? Listen to the podcast. That's one of the things I miss about Terry not being on here today, because Terry during the show has oftentimes said, hey, Jill, Sean's talking about you. May want to listen. So nobody do that to me. All right. So, David, you had some really good thoughts. Let me turn it over to you.
Yeah, so I mean, it's certainly with the contract management, like you're saying, it not only has to do, and I look at from the other side of this, is not just that it has to do with the financial impact. Certainly, when you're paying for all these licenses, you're paying for things that you don't have. The potential that I see, the risk is anytime there's an additional name still left out there who's no longer part of your practice, and somebody accidentally enters that name on a claim. Now you have that compounding issue of somebody else now ends up on a claim. We had this happen multiple times where we would get records and they were just selecting the drop down. They hit the first name on the drop down and they set it in. Doesn't mean it was right, but that position, sometimes they were dead. They were no longer at the practice. They'd been sanctioned. There was various reasons why they should not be on that claim. But when you have all these things out there, the potential where something's going to get misinput on a claim that's a challenge. And your defense is, we got to kind of go back with the records. If you should have known, you should be managing your practice, and you should know who are the people that's supposed to be being billed.
Yeah, and I don't deal with this particular part directly, but what you all are saying just reminds me of when I'm working with people on just their revenue cycles in general, especially when they outsource the work, because there's so much that is done that they are just expecting to be hands off and stay hands off. And, there's so many people that are having to close practices, file bankruptcy, do all of these different things because they trusted someone they shouldn't have, or they just left it on, cruise control thinking it was going to handle itself. So I can see how that's just another expense that's getting thrown away.
You bring up a really good point, and Jordan, I want to pick your brain on this one as well. So, when I hire somebody to come into our company, I ask for a number of references, and I pick up the phone and I call those references, and I ask questions like, number one, if you had the chance to rehire this person, would you? And if they say no, that's all I need to know. I don't ask why. That's all I need to know. But if they say yes, I say to them, okay, so what is it about this person that is making you say, man, if I had the chance to rehire them, I would do it? And I think, Stephanie, to your point, that's part of the problem that's happening. I think there's a lot of desperation to try to find people, because for whatever reason, there's still a lot of practices that are saying to us, hey, I'm working on a skeleton crew. We're trying to get people to come to work. We can't get people to sign on with us. We're offering, but whatever that is going on. But I mean, Jordan, from your perspective, I mean, you went through the law school in Texas as well. I mean, at what point are people responsible, especially knowing that we have an obligation to check the OIG, the LEIE? We have an obligation to check the excluded providers, the sanctioned providers, the physician database. We have to do criminal background checks. I mean, at what point do people have to say, okay, I got to put the brakes on, because we're failing ourselves? Go ahead.
You can't. And I think everybody gets caught up in this. It's speed. So what happened is, to your point, they try to cut staff. They run the skeleton crew. And, now business has picked up. I need to bring on more people. I can't scale. I can't bring on people fast enough, which then lowers the bar for them of who they'll accept to bring on. And you bring up a good point of the physician, but checking the exclusion list and stuff, but also for office staff, I mean, your RCM workers, your nurses, your assistants, all that. I mean, all these people need to be vetted. And I think a lot of people now, they're so quick to just bring on anybody. I need a body. And to your point, the onus is on the practice, because this may cost you more in the long run. And, hats off to the practices that can, I guess, push or live by the motto, hire fast, fire faster. But that, if you work in a hospital environment, that ain't happening. It takes 3 years to fire somebody. But I think, sometimes hiring is guessing, and we can say hiring's guessing, firing's knowing, but due diligence on hiring, I feel like it's become less deep and very shallow, very quick, and we're not doing it, and you're setting yourself up.
David, when you are conducting an investigation, either under the UPIC or under what used to be the ZPIC, right? I think one of the things that people don't recognize is, if you have somebody working for you, even if they're not in a clinical position, they are indirectly impacting your revenues with the Centers for Medicare or Medicaid Services. So it could even be a candy striper working for your hospital, that if that individual has been excluded, there's an actual formula that you have to go all the way back to the date of first hire. You have to figure out the amount of money that you've collected on that individual. And then there's this whole financial calculation. Can you speak a little bit to that? And Joe, I don't know if you've dealt with that from a legal perspective before.
Yeah, so those were, I mean, those, I'd say from the investigations, those are the easy ones, because you had the documentation. I know when you were excluded. I know when you were kicked out. So to your point, you do that calculation. There can be, a CMP tied to that as well. So you're looking at, the price per claim. And I think it's up to 23,000 now that they can fine you. So yeah, there's a lot of financial implications. In addition to that, you're potentially probably going to get into you could get into a corporate integrity agreement. They're going to be looking at your compliance plan. So now your costs all just went up just because you didn't do it on the front end. And I think the thing that people do, and I think they do a good job of checking up front, but they just check once. They don't bother following up. So to your point, Joe, about, hey, you should be scheduling these things. You're checking your thing. People's status change. They may not tell you, or if you have a big organization, you don't know. So it's not just check it once, but you need to continually verify that, because something could change, and it's your job to keep yourself out of risk. They're supposed to self-report. They may not. So you need to have these things in place.
Yeah, that's a good point. And from a sanction standpoint, I mean, there's a lot of vendors out there that will help you do it relatively inexpensive. You just got to make sure that the files are uploaded and current. That will check across all publicly reported agencies. Not every state has everything publicly facing. Many do, but you can do it relatively inexpensive. If you don't have a lot of staff turnover change, you can do auto checking, so it can happen. But I think, from onboarding, and not just employees and contractors, but like 1099 type staff, but also your vendors. You need to make sure that you're also checking them as well. And I think that gets missed sometimes.
Such a great point. That's something, Stephanie, I don't know if you were working with me on the client, but one of the things that I created as part of this comprehensive compliance program that we did for a client was a vendor validation, where we would actually gather all the information on the vendor. We would identify all of the people that worked at the vendor. They would have to give us a list. And we actually vetted the vendor on the LEI. We used a program. Oh my goodness. The program, it's screening, Exclusion Screen. Exclusion Screen is the name of the company. It's really reasonable. I think it's like anywhere from $7 to $10 per person per month or something like that. I don't know, but they look at everything. And sure enough, that vendor had not only one, but 3 individuals that had been excluded from participation in the federal payer programs. 3. And when we sent it back to them, they had no idea. And that's a disclosure that they have to make to all of these organizations that they have been contracting with, because these organizations potentially have an obligation to disclose the fact that they engaged with a vendor who was employing excluded individuals. I mean, that's a huge mess. That's one of those messes where had you done the legwork up front and you paid a little bit of money, it would save you buckets of money on the back end. And forget about the money, think about the headaches. All right. Well, I think we've done a really good job of hitting, multiple topics for today. Again, I want to apologize for the issue we had here on my end, but with Stephanie, Joe, Jordan, David being the professionals that they are, they kept the program running while we tried to figure out what was going on my end. My expectation is next week, they're telling me I will be in my brand new office. I will have great lighting and I will no longer look like I'm hiding in the shadows. But hopefully you all have been able to hear me nice and crystal clear. So I want to thank Stephanie, Joe, David, Jordan. Y'all have been fantastic. Great roundtable conversation today. We will be back on our now regular schedule now that everything is being sorted out. So I will get that published for everybody in the coming days. So you'll know when and where to catch the compliance guy Monday roundtable with our cast of characters. Terry and I will be back tomorrow morning with a brand new hashtag Terry Tuesday. Can't wait, as always, to hear what she tries to stump me with tomorrow. So until then, remember, y'all be good to yourselves, but more importantly, be good to each other. Take care.